Nigeria, the worst country to give birth in. We're looking at about 777 for every 100,000 live births that women are still dying.
It's a big blow to the health system, to everybody, the entire family, the entire community, even the country if a woman dies. I've seen the statistics, it's crazy, it's embarrassing.
Some of these causes that leads to this maternal mortality are actually preventable. Why then are we still having these issues when some of them could actually be prevented?
Delay in getting to the health facilities. Even at that health facility, they may not have the facilities. They have to refer you again to a higher center. Culture now comes in. The woman is convulsing. You decide to go to church first. What would the church do to save that life? We have lots of unsafe abortions because these women come down with a lot of complications. It's so shameful when you look at the statistics. I don't even want to see it because it's bad.
How much do you think finances influence or would help to curb maternal mortality? An article was published by BBC News on June 3rd, 2025, and the caption of the article was Nigeria, the worst country to give birth in. And in the report, if you read down the report, it states that Nigeria has one death every 7 minutes when it comes to giving birth. That's maternal death. And then I wonder, why is this very peculiar to Nigeria? And when I look at the countries, the top countries, the top 10 countries, I also realize that this is not just a Nigerian problem. Nigeria may be top of the list, but 9 of the 10 countries were African countries. So today on this episode of the Intimate Matters podcast, we want to talk about maternal mortality and what is happening that years and years and, progress as it pertains to medical sciences, but then women in Nigeria, we're looking at about 777 for every 100,000 live births that women are still dying. And I'm not just be discussing alone. I'm here with a medical professional, Dr. Utube Tukma, who specializes in obstetrics and gynecology. And he's also a published researcher in the International Journal of Obstetrics and Gynecology. Thank you so much for joining us today, Dr. Utube.
All right, thank you for having me.
All right, sir. So I'm going to go straight to the point. The very first one, maternal mortality, practically away from what is written in textbooks and the rest of the thing. What does it mean to the common man on the street who is walking on the street, or the common woman on the street?
Well, once the people hear of maternal mortality, they will know that a woman died from childbirth. But we have to define it properly because if a pregnant woman had an accident, you can't call that maternal mortality if she died in the process. So there has to be a clear definition so that everybody does not attribute everything to or as maternal mortality. So when we say maternal mortality, it means a woman died during pregnancy or within 42 days after termination of the pregnancy. And it does not depend on the site or the location of that pregnancy or even the duration of that pregnancy. That's to say, if it was an ectopic pregnancy, that's also maternal death. And if the woman had an abortion, maybe within 6 weeks, she terminated the pregnancy and died as a result of the complications of that. That's also maternal mortality. And even if it's from causes that maybe related to, or maybe we say aggravated by the pregnancy. For example, someone has a heart disease. He was counseled probably not to get pregnant again because it can worsen her condition. And if by chance she got pregnant and died as a result. So that was aggravated by the pregnancy. And we try to exclude any accidental or incidental causes, like I said earlier. So you can't say someone had an accident during pregnancy and that's maternal mortality. No. It was because of the accident, not because of pregnancy-related issue. So that's how we define it. But generally, people will hear, a woman died during pregnancy, that's maternal mortality. To a great extent, they are right. But we in the medical profession, we have to define it properly. So that's maternal mortality. to us.
All right, because thank you for pointing that. Because, like you said, when there is maternal, that's when a woman becomes pregnant and death happens. It seems that people tie everything. She fell down and died. They tied to the pregnancy. She jumped on something and died, and they tied to the pregnancy. And also, thank you for shedding light because oftentimes, when we look at it, most times, especially when looking from the layman point of view, people see that it has to be related to pregnancy, what I would call pregnancy complication, not knowing that, like you've mentioned abortion, for example, and the rest. So I want to look at, I want to hear from you, like over the years that you've been in the medical space. I'm sure that you've experienced it. Is there like, can anyone come to your mind, one that has stood out for you over the years of the maternal mortality that you've experienced?
This is actually something very sad. And it's not something that you want to recall because we've seen a number of situations that you look back, you wish something could have been done or something differently could have been done. And sometimes you look at it and you're like, if probably these things, maybe you had this equipment, that wouldn't have died. That woman wouldn't have died. And then you kind of do maybe kind of an audit. Oh, this is what got wrong. This is what. So it's not something I want to recall, but it definitely comes to mind a number of times. But the ones that we celebrate most, and those ones that we call near miss, those women that would have died, that you actually, because of the interventions,
Okay.
you're able to save that life. So those are the ones that I will be so happy to talk about that.
Okay.
But if it's the ones that I recall, I don't want to recall.
All right, because like you said, it's a loss of life, and it's sad. I could even see from your eyes as you was talking about it. Sometimes the memory come flooding in. So let's talk about because before we get into like some of the causes, because you've said something like some of them would have been averted and the rest. But let's talk about this near miss. And use it as a point of, for people to learn about it, so that it could be prevented going forward.
Yes, so one of those days, we were medical students at that time, so it wasn't even involved directly in the management. We were just there in the labor ward for observation. A young lady, first pregnancy, had severe obstetric hemorrhage, severe bleeding after delivery. We have our protocols, the management plan for if you have those kind of cases. So everything was done, but this young lady kept on bleeding. So the only thing that could be done at that point that was available, though yes, in higher centers, maybe some other countries, they can do what we call uterine artery embolization, all those stuff. But here we can't handle that at the moment in most of our centers. So the option there was to remove that uterus because it was not contracting and she kept on pouring. So, one of those days that you see everybody jumping up and down trying to save that life. So the next state is everybody came in and the woman had the surgery. So the only option there was to remove that uterus. But it's sad when it's a first pregnancy and you have to take out the womb. But when you look at it differently, if we didn't do this, we would have probably lost that woman. And
still lost the womb.
And lost everything. So, and one case of maternal mortality is a big blow to the health system, to the society. Now, a woman delivers, dies during delivery, leaves the baby, leaves the man. Believe me, I don't pray for such a thing to happen, but I can imagine putting myself in that man's shoe, the husband's shoe. I don't think life will make so much sense at that point. Because who will care for the baby? Maybe you have other children at home. Who will care for them? And how are you going to cope? It's easier. sorry to say, but sometimes if the women have their own way of coping, if a natural way of coping better than the men, if they lose, if they lost their partner. But a man, you'll be so scattered. So it's a big blow to the health system, to everybody, the entire family, the entire community, even the country, if a woman dies. So it's not something that we should allow to happen. We have to stop it. I've seen the statistics, it's crazy, it's embarrassing that at this stage, at this age, we are still talking about so many women, losing so many women because of childbirth. Man, it's shameful, I must say, but we have to do something. Maybe that's why we are here, because
we'll be talking more about the the prevention and how we can help, how everybody can come in to help. Because one thing I've noticed is that people feel, which is I think almost a common thing, especially in our climate, people feel that everything should be placed on government. Yes, we know government have a role to play, but people always projecting almost everything that happens to them on government. But we'll come to look at those prevention. Okay, so you talk about let's talk about why, because I know that some of these things, some of these causes that leads to this maternal mortality are actually preventable. Right. Why then are we still having these issues when some of them could actually be prevented?
Okay, well, first of all, I must say that we've actually come a long way, because things are improving. It's not as bad as it was in those days. So, though we've not done enough, we still need to do more and fast. But we have to look at the delay models in this case. The 3 levels of delay that we often talk about. And first of all, the first delay has to do with the delay in the decision of the woman to seek help, or seek proper help. For instance, just yesterday, we had a case that came into the hospital. The woman was shouting, the sister to the lady that was brought was shouting, screaming, come on. So I needed to know what was happening. So I went down, saw the woman. It's like, okay, the doctor that was on duty, you need to, you have to ask what's happening, even though you're not on duty, in case you need to help. Okay, the story is that she is a known patient with preeclampsia, one of the top causes of death. I think it's even overtaking obstetric hemorrhage, bleeding, because it's quite common, we'll talk about it. So your BP is high, very high, you know about it. And you decide to go to the church. Okay, no problem. There's no problem with going to the church. Yes, it's good. But at least you fitted. So they took you to the church while you were convulsions. And then before they now said, okay, listen, after so much prayers and it was not stopping, they now decided to move to the hospital. That's a delay. That delay in seeking proper attention, proper medical help. The woman is convulsing. You decide to go to church first. What would the church do in that situation to save that life? So before they now finally come to the hospital, probably, maybe, who knows, the baby may even die. As we see some cases, they come in unconscious. Then for some people, the husband factor now comes in. If the husband is not at home, they can't leave. So the husband has to give the woman permission to leave the house. So she has an emergency at home. She stays there waiting for the husband's approval before she can leave. Why are you looking at me like that?
No, because I'm wrapping my head why somebody should know that something is wrong with her. Maybe, like you said, emergency. Maybe she has already started bleeding or the water has broke. So
that's where the culture now comes in.
Okay.
Go to most part of the northern part of this country. A woman cannot leave the house without the husband's permission. Over here, we've seen a number of times. A woman comes to maybe before they even come, they have to wait for the husband to give money. So she doesn't have the money of her own to come and, take care of herself, because we still operate the out-of-pocket system. We don't have health insurance for everybody. So you must come with money to be attended to. So the woman doesn't have any money and has to wait for the husband to send money. So before she now takes the decision to leave the house and seek proper help, you don't know what can go wrong during that period. So that's the first level of delay that we've noted as a problem. Then the next is the delay in even reaching the health facilities. So you look at some settlements over here in Akwa Ibom. I think we are lucky. The hospitals are a bit closer. It's not, but some parts of this country, the hospital can be 1 hour, 2 hours away from where people are living. And sometimes accessible roads, if they have to use bicycle to be able to get to town where the health facility is located. So you have an emergency. The kind of bleeding we see sometimes, that within 30 minutes, your whole blood volume is gone. So how do you get this woman from that location to the hospital? So that level of delay is well noted. Delay in getting to the health facilities. And sometimes, even at that health facility, they may not have the facilities. They have to refer you again to a higher center. And then no ambulance to take you there.
You have to jump on the bicycle
You have to enter keke. Then, So when we solve these problems, we'll have a better result. Then the third level of delay is delay in the health facility, in the hospital, which is also a slap on our face. That's, come on, a slap on our faces, seriously. Because you come to the hospital, the bureaucracy in the system. Go and get your card.
Buy card, do this.
Before they finally attend to in some hospitals, because I've also seen where we have to ignore all those things, save that life. So for some, we have to be truthful to ourselves. Some systems, some of our health facilities, come on, the delay in instituting the medical treatment for that patient also comes in, which is why we have to do our own part. While we are shouting that others should do their own part, we should do our own part in the hospitals. So those are things that we've noted that have really contributed to the maternal deaths. Apart from those other major causes we talk about, but these ones are a problem and we have to fix it.
All right, doctor, thank you so much for pointing out all of those delays, because like I said, oftentimes, I think emphasis oftentimes is always in the last delay, where everybody points fingers at the hospital.
Yes, it's quite annoying, because sometimes they come in, what were you doing at home? What were you doing at the TBA place? Then so it's now that you are expecting immediately you come that the problem is solved. You start, insulting everybody. I don't know.
All right, thank you so much, doctor. Okay, so let's talk about what are the top causes of this maternal mortality, either as leading to it or as predisposing a pregnant woman to the possibility of mortality, either during the pregnancy or maybe during delivery or after delivery.
Well, I think the preeclampsia, eclampsia issue that is gradually overtaking the obstetric hemorrhage. Let me explain. When we say a woman has preeclampsia, it means she has a high blood pressure during pregnancy. For some women, they did not even have any blood pressure issue.
Okay,
but
before
the pregnancy. But during the pregnancy, from around 20 weeks, notice that the blood pressure is going up. And then for some women, they can start excreting proteins in the urine. So they go to pee, we have to do urinalysis when the women come to the hospital. So when they come, we check the urine for glucose, protein. Notice that there is protein in the urine. It should not be so. The kidney filters it completely. So we are not supposed to be excreting urine. So, but in this group of women, for most of them, they come down with that, what we call proteinuria, protein in the urine, and then the high blood pressure. For some, they may not even have that. But if you do other tests, for example, you do a liver function test, you do a kidney function test, you may notice some derangement and all those things. So you can easily pick, this is a case of preeclampsia. Now, when this condition progresses to the extent that the woman starts convulsing, that's when we say the woman has eclampsia. The other one is pre-eclampsia. It comes before the fit. And even before this fit, you can have some symptoms that tells us, oh, this is a severe case. This woman is likely to fit if she's not attended to. For example, she may have severe headache, may not see clearly, may complain of gastric pain, vomiting, and so on. May not even make adequate, she may notice that she's not even urinating again properly. So it affects the whole body system. So it seems to be overtaking obstetric hemorrhage in the sense that we can now handle the bleeding more effectively. We have the medications, if a woman is bleeding, you have oxytocin, you have glutamine, you have carbetocin, you have those things. And apart from that, our health system, like I said, is even becoming more efficient. You can easily identify the cause of the hemorrhage. If something that needs urgent surgical intervention, you can, rush in and, do something about it. But that preeclampsia issue is a major issue, is a major problem because the cause is unknown. You can't really find the exact cause. It's just theories. There are lots of theories here and there. You can put together and say, okay, this is likely what is happening. But so that's the top issue. Then for some women, like maybe mostly in fact, the whole of Nigeria, let me say so, because abortion law is like, it's strict. You can't walk into the hospital and say you want to do an abortion. It would be like you are coming to tempt the health worker.
Yeah.
So we have lots of unsafe abortions. And so that's also a factor in maternal mortality because these women come down with a lot of complications. Some of them. Because at the end of the day, they can, rupture the uterus. In the process of introducing the instruments, they come down with a lot of infections. And because there's something that they
are doing
secretly before they now come to the hospital or they now open up to their parents or their young girls mostly. Before they open up, it's when the complications have set in and it's a problem. Apart from that, we have these cases of obstructed labor. Obstructed labor. A woman is in labor, labors for days. We see that in the traditional birth settings. They will keep you. Don't worry, you deliver.
Hebrew women.
You stay there for 24 hours. No, don't worry. It's just starting. 48 hours. In pain. And then when the baby sometimes has died, they now appear in the hospital and expect magic at that point. So for some reason, some of these we also lose some of these women, sadly, because they come in late. They come in late before they finally drag themselves out of that place. I don't know. So that's also a major issue. I've talked about sepsis. So these are some of the issues we've and then there are other minor issues like anemia, not having enough blood level. Some of these women, they don't take multivitamins, especially in the villages. If they don't come to the hospital for antenatal care, they don't take their hematinics. So at the end, the blood level is low. Before you know it, they can go into heart failure in the process. Even malaria can cause a whole lot of problem in pregnancy. So these are some other minor issues, but those are 5 are the top 5 causes that have been identified.
All right. So because you talked about women staying for so long before coming to seek care, and we know around here there is a whole lot of throwing around of the Hebrew women thing, throwing around, and people talking about people looking at cesarean section as, I wouldn't want to know, although gratefully the perspective is changing gradually. I think more people are now more open to it. More people are now embracing it. Because before now, you see people, like you said, especially in traditional settings, where I've seen a child tell the mother that she wants to go for an elective CS, that she's pregnant, or when she gets pregnant, she wants to give birth via CS. And the mom is very mad at the child. from quoting things like "you are a disgrace to me," "I gave birth to you from the vagina," "you should also give birth," and we have a whole lot of things that women who give birth via CS are not real women and the rest. But all of those things are false. The aim is to get pregnant, have a pregnancy, have a healthy pregnancy, get to delivery, deliver your child, mother and child is safe, and we go home. And then we want to come to culture and religion. I think especially here with quite cultural people and religious people, how do they play into affect this maternal mortality? How are they also influencing? How are they also contributing to this burden that we have in this as it pertains to maternal mortality?
Well, there is a lot of awareness now. So, women come to the hospital. Some come in, they request for cesarean section. They don't want to go into labor. So, somehow, you realize that they have to be properly counseled. Surgery is still a risk. I don't think vaginal delivery is still the best. That's the truth. Vaginal delivery is still the best. So I don't think we have to make this emphasis of cesarean section as being okay. You can walk in and do cesarean section. No, we have to talk about the risk. So that you must make an informed decision. If you want to deliver through cesarean section, you need to know that there could be complications from the anesthesia. You need to know there could be complications from the surgery. So you have to put all these things together and then make an informed decision. Yes, vaginal delivery, you can also have some complications. But put everything together before making the decision to go for cesarean section. That's just to address the first part of your question. Then the cultural aspects. We've seen a lot of cultural belief systems that affect the choices that people make. For example, some people believe that hospital is just a waste of time. So you talk to some women, we have some wonderful ladies here. If you talk to them, some of them may be like, I have my own traditional. I don't want any.
Yeah, my grandmother used it. My mother used it.
No, it's a cultural aspect. They were there before the medical system came in. So somehow you can't just eliminate it completely. So that aspect is still there. People don't really believe so much in our health system to a great extent. Some people have also seen to come in because of some of the challenges we have. You come in, may not be properly attended to, you feel they will talk to you anyhow and so on. They tell you, no, let me go to this. So it's something that we have to work on too, so that people can build trust in the people. So that when they come to the hospital, they know they will have the best. So another aspect of the culture, I know I mentioned a few earlier, like that religion. Somehow people believe a woman should not leave the house without seeking permission from the husband. Somehow that's also a problem. And maybe we have some taboos too, that, okay, for example, a woman is in obstructed labor. You may be surprised to know that some people still believe that it's because she cheated on the husband.
Yeah.
That's why she cannot deliver vaginally. So they will keep you there.
And ask you to suffer for the consequences of what they think you
did. Funny enough, they'll make these women confess what they never did, because when the pain is too much,
you have to
just start saying some things just to be relieved. Meanwhile, it's not actually you are just looking for a way out for your life. So these are some of the things that we've seen, and maybe may not really affect it. May not be so common again, the female genital mutilation aspect, that sometimes could may not really affect vaginal birth to a great extent, but to some extent it might lead to some complications in the process of vaginal delivery, tears that could lead to bleeding, severe bleeding, because somehow may kind of cause some scars around there that tightens the perineum. So in the process could lead to tears and then bleeding, especially if it's not well managed. Maybe it was in a traditional setting. So I think these are some of the things that we, maybe as we go on, if I remember
Okay,
some
so
things.
I also wanted to ask, because you mentioned, because this is a problem, we've seen that over the last couple of months, there's been a whole lot of stories on social media about pregnant women losing their life due to so many different reasons. You've talked about the delay in even seeking the care. But then it seems that when everything is said and done, most of these issues always hinge on finances. Where they will say the husband went to the hospital, or they went to the hospital, they didn't have 200K to pay or 500K to pay. What role or how much do you think finances influence or would help to curb my maternal mortality?
Well, it doesn't really always boil down to finances, because I'm well aware of a lot of programs that the government is doing. In fact, right now, if you come in with an emergency to the teaching hospital here, and think some other teaching hospitals have been selected, everything is done for you free as a pregnant woman. So it's not really about, I don't think it's really about finances. And we've also come to a point that most of the time, the hospital, we have public hospitals, they mostly put the lives of the patients first, because they know the efforts that the government is making to ensure that someone doesn't die because of money. Was there? So, well, somehow I disagree with that aspect that it's actually
No,
finances.
what I'm asking is the issue of, like you talked about, especially finances in the aspect of the woman. So how
Okay.
much does a woman, if I should call it financial independence, or
Okay, yes. Yes, since we are still operating the out of pocket model, and most times you have to come to the hospital, you must pay for this and that. So we emphasize a lot of female education, female girl child education, girl child literacy is very important. Women empowerment. Now, one of those days in the hospital, a woman came in labor and the husband was in Calabar. This woman needed an emergency CS. She called the husband. The husband started arguing on phone. Why? Eh? Why? You have to leave that hospital. No. He started arguing and arguing and arguing why
they should be a
there
CS?
should be a CS. This is where the aspect of a woman having her own money comes in. The mother was there. Started saying, she brought money and we did everything for her. That's one beautiful aspect of a woman not depending on a man for everything. Because some men do not step in when they should. They argue a lot. They won't even be there. They will be talking on phone. They want to question you on phone. And it's bad. So a woman having her own money is something that I feel is so important. Female girl child education, girl child literacy is very important, so that they can take decisions for themselves.
All right, because beyond just having the money, you talked about literacy, because some of them have the money, but they don't know what to do with it. But sometimes you see some of them come to the hospital and they don't know that they have a right as a person to, make medical decisions for themselves. So you see a woman, you're being told you have obstructed labor, for example, you need a CS, emergency CS, and she's like, that she can't sign it. And they were always like, the husband needs to sign it, and that they cannot do anything for themselves. And if their husband does not say it should be done, that it cannot be done. So it's essential that you as a person, knowing that this is the process that you want to walk through, that you also have the right information and the knowledge to know what to do for yourself. So we've talked about a whole lot of things that cause this. So what do you think can be done either individually. Okay, I want to start this way. I don't want to start. I said I won't start with government first. Let's start with our institution. What do you think can be done for us to? What do you think can be done to help reduce it institutionally and also as individuals?
Okay, to reduce maternal mortality.
Mortality, yes.
Okay, well, the prevention have to start with at a very primary level. So we talk about, like we've said, girl-child education, girl-child literacy, all those things. Then even girl-child nutrition is also very important for healthy bone development, healthy growth, so that her pelvis can grow properly. So when it's time to deliver, she knows she has an adequate pelvis. Then we also talk about things like avoiding child marriage. Lots of people, you can't go and marry an underage child, and then she may have lots of complications during pregnancy and during delivery. Then we also move to talk about family planning, because the higher the number of pregnancies, the more they risk. So if a woman has delivered 5, 6, 7, 8 times and still comes back the 9th time, you have to be very careful in that pregnancy, because she can bleed seriously. So the issue of family planning also comes in, at least, so that it's not just to space and have the number of children you want to have. No, that high parity, having too many children, also comes with problems to us in the health sector because of the complications that can come in during that pregnancy, especially at the point of delivery. So apart from this, like you asked about in the health system, what can be done? Yes, we need to really upgrade the health system. Sometimes you enter some of our hospitals, you feel sad. And the less equipped the hospital is, the less the motivation for the staff. You come in, probably you know what to do, but you can't do it because you don't have. So what's the motivation in working there when you can't do anything? You understand? So when our hospitals are well equipped and we have a good referral system too, and the health centers every community should have a health center, so that at least we can start from that level with well-trained staff. Seriously, the staff should be skilled. You keep training and retraining the staff. Things are changing every day. Better ways of doing things are coming up. So we should be able to move fast and get things done fast, so that we can compete with the rest of the world. It's so shameful when you look at the statistics. I don't even want to see it because it's bad. We can't be amongst the countries with the top, the most dangerous country to give birth. Come on, we are better than this. So we need to do something, and as individuals, yes, we have to step in. We have to step in, because we can't be talking about problems and problems and problems. What can you do to help? At your own individual level, okay, yes, we've advised the patients. We hope they listen to us. Then on our own path, what can we do to help? I think educating the people is very important so that they can make the right decisions. Then we move on to, if you have what it takes to have your own hospitals, expand it, train people, and then the government has to also step in, before I forget, to see how to reverse this japa issue. One day this country will wake up and discover,
and there's no health professional.
And discover government has to. It's not like trying to force people, tie them down. No.
Make them want to stay.
Make them want to stay. Make them want to come back. We've lost so many hands, and it's bad. So when you see some of the challenges that we have, it's because the people that are working are overwhelmed. They are tired.
That's quite true.
So we have to see what we can do to reverse the situation. Then you as a person, if you can raise money and build medical school, nursing facilities, nursing schools, do it. So we train more people to replace the ones that are leaving.
All right. So that's doctor seeing the potential in me. So we're looking at how we're going to be building more schools and to train more
We have
medical
to build more
professionals. And like he had said, one of the key things to do to help prevent this maternal mortality is the aspect of education. And that is why we sit here on the Intimate Matters podcast to bring to you knowledge like this that will help you to make better and more informed choices. And you know that on the Intimate Matters podcast, we talk about everything that pertains to your sexual and reproductive health. And do well to, if you're not already subscribed, do well to subscribe to this channel. Share this video to people who should know this. You know a woman, there's a woman in your life, your sister, your mom, your neighbor, you have a woman in your life. Even to the men also, because I believe that if men also have this information, have this knowledge, like Doctor had said, most of these arguments we see in the hospital where you are asking why she should be doing CS would drastically reduce, if not, gone totally. So do well to follow us. We're also on TikTok, we're also on Instagram. You can find us on Facebook. And if you check the description on our YouTube, you see our WhatsApp group, our WhatsApp channel, where you can join and get to interact with us. And we'll be glad to hear from you. Thank you so much, Dr. Utbe, for coming in and, shedding light on the issue of maternal mortality, starting with the fact of, defining maternal mortality. I think it has really, I'm sure that the people who view this and who are viewing this would really see and understand better, because everybody usually felt that it's just anything that, in fact, they used to feel that it only happens in the hospital. So once a woman goes to the hospital, anything that happens. But then government, individuals, corporation needs to come in. Let everybody put their hands together, and we're going to play in and see how we can change this narrative. Nigeria should be top in better things and not maternal mortality, like the BBC report I quoted earlier had said. So just before you go, sir, this is from your own point of view. If you had all the power and all the resources and you were to change something that you think to a greater extent will alter this trajectory that we're seeing for the positive, what do you think it can be? Something that could, one or two things you can do and alter the trajectory that we're seeing when it comes to maternal mortality in Nigeria?
Well, that's a tough one. Because maternal mortality is multidimensional. So it's difficult to point out one thing you can do and change the trajectory. But maybe we think of maybe building a stronger workforce. So we have to educate, train more people to, have the skills to manage pregnancy and its complications, and probably even have highly specialized skills too. Because sometimes what we have may not be enough. So highly specialized skills and probably more education, educate people more in the communities. So at least that one, I can do it easily. The other one, I can do that one, this one immediately, even now. We can start spreading the message. But the other ones, we need more time, more resources.
All right, so start it right now, like Dr. Utba said. Start spreading this message right now as you're seeing it. Like I said, share it across to everyone. And then we call on to everyone, the government, individuals, corporation, philanthropists. Let's see how we can improve our workforce. And one way to improve our workforce is to make sure that we have the right equipment in place. Now, not just the equipment in the hospital, that's one. We talked about the issue with delaying to getting to the facility. Please, if you know that you are in charge of having the resources of a particular people, channel that resources to create access routes and other things that will help to ensure that these pregnant women can have access to the right form of care. Thank you so much once again, Dr. Utbe, for coming. And I'm very amazing personality. Someone who is very passionate about the health of mothers and also children. He runs an antenatal class. Also has a community on Facebook, I think Healthy
Women's Health Plus.
Women's Health Plus. So if you're on social media, go out there and check it out. Women's Health Plus, an amazing community on Facebook where you can learn a lot about women's health, especially as it pertains to pregnancy and delivery and childbirth. So this is where we draw the curtain for today on this episode of the Intimate Matters podcast. Thank you so much for sticking around with us. We were here discussing maternal mortality and how we can reverse the reports according to this BBC report we had in 2025 talking about Nigeria being the worst country for you to give birth in. And we hope that when you listen to this, you do your part by getting the right information and sharing this knowledge, that you're going to contribute in your own way. The government will come in, cooperation will come in, and putting our hands together will contribute and ensure that we reverse this trend. My name is Nosa Kwawakwan. I'm your uncle on this podcast. Until we come your way next time, it's bye for now.